Hi, my name is Hisham bin Masoud. I am a general practitioner consultant and emergency medicine consultant and consultant with the UNICEF and IMCI program. Today we have a new topic we will present it. Its title: Assess, Classify, Treat, Follow Up, and Counsel for a Fever in the age group between 2 months until 5 years. Our objective today is to assess and classify the sick child complaining of fevers, treat the child complaining of a fever, counsel the mother for fever, and give follow-up care for fever. As we know all, our approach in integrated management of newborn and child illness, we have 4 steps. The first step, assess and classify the sick child. The second step, treat the child. The third step, counsel the mother and give follow-up care. As overall pictures of management child complaining of fever, as we know that the under 5 years old, the fever is one of the main complaints and main symptoms presented in the primary health cares, um, and as it's common, it have some cases have a serious illness. So our approach, as we understand the approach in IMCI, is first step after arrival in the primary care and taken personal information from the receptions, go to the triage site, where at the triage site we will have some information will be taken from the general practice nurse or clinical nurse or triage nurse. This information, mainly after welcoming, is to exclude if the child have any general danger signs. And I just remind you about the general danger signs is the child is not able to drink or breastfeed, or the child vomits everything, or the child has a convulsion, or he is convulsing now, or the child is lethargic or unconscious. If the child have one of the general danger signs, will be categorized immediately as very severe uh, disease, and by this classification, this child should be referred to the treatment room. If the child doesn't have any general danger signs, we will ask about main complaint. And if the child have one of the main complaints as a fever, we need to confirm that the child has symptoms of a fever. And by this, we have one of the 3 scenarios. First of all, if the child has a history of a fever, or the child feels hot by the mother, or the child has an auxiliary temperatures of reading 37.5 degrees centigrade or above. If the child have a fever, we should look for a specific danger signs. One of the very important specific danger signs for fever is the stiff neck. So we should look and feel for stiff neck. And how we do that? As we know, child with fever and stiff neck may have a meningitis. Child with meningitis needs urgent treatment with injectable antibiotics and referral to the hospital. While you talk with the mother during the assessment, look to see if the child moves and bends his neck easily as he looks around. If the child is moving and bending his neck, he or she doesn't have a stiff neck. If you didn't see any movement, or if you are not sure, draw the child's attention to his umbilicus or toes. For example, you can shine a flashlight on his or her toes or umbilicus, or tickle his or her toes, and encourage the child to look down. Look to see if the child can bend his or her neck when he or she looks down and his or her umbilicus or toes. Otherwise, if you still have not seen the child bend his neck himself or herself, ask the mother to help you lie the child on his back. Lean over the child, gently support his or her back and shoulders with one hand while the other hand hold his or her head. Then carefully bend the head forward toward his chest. If the neck bends easily, the child doesn't have a stiff neck. If the neck feels stiff and there is a resistance to bending, the child has a stiff neck. Often child with stiff neck will cry when try to bend the neck. As you note in this picture, so we have three possible scenarios. One active child been looking around up and down, and by this way you exclude the stiff neck. The other one, you just try to get the tensions, and by this way just make him moving his neck or her neck. Otherwise, if he's unconscious or lethargic, you can use this technique as mentioned before. So if there is any general danger signs or specific danger signs as we mentioned before, the patient should be referred immediately to the treatment room and calling the direct physician to see him and assess him quickly and give him the pre-referral medications including an antibiotic prior to referral to the hospital by the ambulance to the emergency department. As we mentioned before, so any child have any general danger signs or stiff neck, we classify him as very severe febrile disease. And by this way, the child should be referred immediately to the treatment room and giving a pre-referral medications before transferring urgently to the hospital. Otherwise, if the child doesn't have any general or specific danger signs, the child can be waiting in the waiting area before going to the examination room to be seen by the physician. In this way, there is two possibilities, one in the yellow zone, other in the green zone. In the yellow zones, there is a classification, about 5 classifications. One of them is measles, rickettsia, possible urinary tract infections, possible malaria, and fever with known source, and fever with no apparent cause. Or maybe we classify him or her as a fever only. So this is only an overview. Now we go in detail about assessment for fever. So after transferring waiting area and seen by physician, the direct physician should ask for how long the fever are. If more than 7 days, has fever been present every day? Ask the mother how long the child has had the fever. If the fever has been present for more than 7 days, ask if the fever has been present every day. Most fevers due to viral illnesses goes away within a few days. Fever which has been present every day for more than 7 days can mean that the child has more severe disease, such as typhoid fever. So this child should be referred for further assessment. Another question you should ask, has the child had a measles within the last 3 months? As you know, measles damages the child's immune system and leaves the child at risk for other infections for many weeks. A child with fever and history of measles within the last 3 months may have infections due to complications of measles, such as diarrhea, pneumonia, or eye infections. Then you should ask, if the child is 2 years or older, you should ask, does the child have a pain on passing urine or passing urine more frequent? Most probably, if the answer is yes, the child has urinary tract infections. Then you should ask, Has the child traveled during the past 2 weeks, and if so, where? In Libya, as you know, there is no malaria risk, but the child may have traveled to malaria risk areas, especially in Africa, South Africa regions. If mothers tell you she has been with the child in area where you know there is a malaria risk, the child may need to be referred for further assessment to exclude malaria. Look for runny nose. A runny nose in a child with fever may mean that the child has a common cold. If the child has a runny nose, ask the mother if the child has had a runny nose only with this illness. If she is not sure, ask questions to find out if it's acute or chronic runny nose. When malaria risk is low, a child with fever and runny nose doesn't need anti-malarial medications. This child fever is probably due to common cold. Look for any bacterial causes of fever. Look for signs of possible bacterial infections that can cause fever. For example, local tenderness, refusal to use a lamp, hot tender swelling, red tender skin or boil, lower abdominal pain in older child. Remember that obvious causes of fever also include a cough or difficult breathing, main symptoms which have been already assessed on the ear, or an ear problem or sore throat that the next main symptoms that will be assessed. Look for signs suggesting measles. As we assessing the child with fever to see if there are signs suggesting measles, for a measles look for generalized rash and for one of the following signs: cough, runny nose, or red eyes. So in a measles we look for generalized rash or signs suggesting of measles like cough, runny nose, red eyes. Then we look for signs suggesting rickettsia. Assessing a child with fever to see if there are signs suggesting rickettsial infections. Look for petechial rash on limbs and trunk, and also on palms and soles, and no cough, runny nose, or red eyes. Rickettsia in our area, Libya region, there is a rickettsia corneae complex. This is the most common part, and it's transmitted by a tick, which is the main vector, and also the animal who are working as a vector is dogs. Rickettsia have many signs and symptoms. One of these fevers, which is most common, about 93% of cases, in addition to the rash, which is in 94%. And there is local lymphadenopathy. It's only in nearly half of cases. Headache, about 1/3. Arthralgia myalgia, about 40%. Arthritis, less than 1%. GI symptoms, about 1/4 of cases. Hepatosplenomegaly, about 2/3 of cases. Orchitis, about 0.2%. Conjunctival hyperemia, it's only in nearly about 12%. Meningism, less than 1%, and meningitis. Do urine microscopy and strep test. As we mentioned before, if the child aged 2 years or more has a dysuria frequency, or if no cause of fever has been identified and the child doesn't have a severe classification, require urgent referral, do urine microscopy and strep test. Microscopy, when we do it, look for leukocytes, or what we call pus cells. If the leukocyte or pus cells more than 10 or more per higher power field, we consider it positive. We do strep test. Strep test is a rapid screening method for urinary tract infections. And what we should look for? We should look for nitrate pads and leukocyte pads. If one of both are positive, then we should consider the child have a UTI. So positive leukocyte test and positive nitrate test normally, but not always, indicate a presence of bacteriuria. We do CBC if available. It is only requested if the child not fit any classification in the yellow area, and the child should be above 1 year of age. The total leukocytic count is less than, if it's less than 4,000 or more than 12,000 per millimeter cubic, it's considered serious severe disease, and the child needs urgent pediatric consultation. So after finishing assessment, we should collecting all of these data and interpretation into a classification. So now the classification become either the child have a generalized rash and cough, runny nose, or red eyes, and by these symptoms we classify him as a measles, or generalized rash, including palm and soles, and no runny nose or red eyes. So by this way we categorize him, classify him as rickettsia. Or by doing urine test was positive, and by this way we classify the child as a possible urinary tract infections. If the child traveled to malaria area, risk area, and there is no obvious cause of fever, then we classify him as a possible malaria. If the child is less than 1 year of age and the child temperatures is 39 degrees centigrade or more, or the child is irritable, or the total leukocytic count is less than 4,000 or more than 12,000 per millimeter cubic, or fever is present every day for more than 7 days, so we classify him as fever with no apparent cause. Finally, fever with no obvious possible serious illnesses and no other symptoms mentioned before, so only we classify him as a fever. So by these categories we have 3 colors zone. We have a red one, or pinky, as a very severe febrile disease, and we have the yellow one, measles, rickettsia, possible urinary tract infections, fever with no apparent cause, or fever with apparent cause. Finally, fever as a green one. And now we go to the treatment section. Treatment section for a child with fever. As seen, every classification has a specific treatment. For a measles, for instance, we should give 1 dose of paracetamol in a clinic if fever high more than 38.5 or more. If a measles now or within the last 3 months, we should give a vitamin A. If measles now, we should notify the case. We advise the mother when to return immediately. If the child classified as a rickettsia, we will give 1 dose of paracetamol in the clinic for a high fever, and we give azithromycin for 3 days. Advise the mother when to return immediately and notify the case for NCDC. If the child classified as possible urinary tract infections, we give 1 dose of paracetamol in the clinic for fever high fever and referred the case to the pediatrician. But if you can work with the case, you can manage according to your experience. If we could classify the child as a possible malaria, we will give one dose of paracetamol in clinic for high fever. We notify the case and refer for pediatric consultation to the infectious department. If the child classified for fever with apparent cause as, as a boil or carbuncle or a mass, and then we should manage according to your clinic guideline in your practice. If the child classified as fever with no apparent cause, we give one dose of paracetamol in, in a clinic for high fever and refer for pediatric consultation. Lastly, if the child only classified as a fever, we only give one dose of paracetamol in a clinic for high fever and we give appropriate antibiotic for treatment for any identified bacterial cause and advise the mother when to return immediately and follow up in 2 days if fever persists. So the detailed about medications. As you mentioned, we should teach the mother to give oral drugs at home and we should give her some instructions. So follow the instructions below for every oral drug to be given at home. Also follow the instruction list in each drug dosage table. We should determine the appropriate drug and dosage for the child age or weight. To tell the mother to the reason for giving the drug to the child. Demonstrate how to measure a dose. Watch the mother practice measure a dose by herself. Ask the mother to give a first dose to her child. Explain carefully how to give the drug, then label and package the drug. If more than one drug will be given, collect, count, and package each drug separately. Explain that all tablets or syrup must be used to finish the course of treatment, even if the child gets better. Check the mother's understanding before she leaves the clinic. About the antibiotic treatment, in rickettsia, we give one dose of paracetamol in a clinic for high fever. We give azithromycin orally for 3 days. It's azithromycin suspension, 10 mg per kg per dose once daily for 3 days. And we should not forget to notify the case for NCDC. About the cases need notification from the classification, we have a measles, malaria, rickettsia, antibiotic medications to reduce the fever. We know that the paracetamol. So we should give one dose of paracetamol in the clinic for a high fever. And we give paracetamol at home every 6 hours, or if the fever or pain persists. According to the age group, we categorize it into 2 groups. From the age 2 months up to 3 years, that means the body weight will be between 4 kilo to less than 14 kilogram. The syrup dose will be 4 milli, which is in the concentration of 120 milligram per 5 ml. Or if the concentration was 250 milligram per 5 ml, it's only half a dose. If the child is 3 years up to 5 years, which is the body weight will be between 14 milligram to less than 19. So we give him 6 milli in a concentration of 120 over 5 milli. Other consideration for possible cases in fever classification. In the measles, we give one dose of paracetamol. In a clinic for high fever, we give paracetamol every 6 hours. If measles now or within the last month, we give vitamin A treatment. If measles now, we notify the case. About the vitamin A doses, give vitamin A for treatment if the child has a measles. We don't give if the child has had a dose of vitamin A within the past month. Always record the dose of vitamin A given in the child chart. So if the child is age between 6 months up to 12 months, we give him 100,000 unit. If the child is 1 year of age and older, we give him 200,000 unit. For possible UTI, we only give paracetamol if high fever, and we give paracetamol every 6 hours or pain persists and refer it for pediatrician. And as mentioned before, you can manage the case if you have enough experience. But also, we should need to refer the case for pediatrician for further management. Fever with identifiable bacterial cause, we manage accordingly. Fever with possible malaria, we give a paracetamol and we refer it for further assessment. Here, fever with no apparent cause. If there is no apparent cause of a fever, we should do CBC if the facility is available. Refer for urgent pediatric consultation if the child less than 1 year of age or the temperature is 39 or more degrees centigrade, the child is irritable, or the total leukocytic count less than 4,000 or more than 12,000 millimeter cubic, fever is present every day for more than 7 days. If the child only classified as a fever, we give one dose of paracetamol in clinic for high fevers, and then 6 hourlies follow up if the fever persists after 2 days. About the follow-up care for fever. For fever follow-up after 2 days, we check the child for general danger signs. If the child about follow-up care for fever. If the fever persists, there is a follow-up after 2 days. Check the child for general danger signs after when they come, and then the child has any new complaint, assess, classify, and treat the new problems, and the treatment. If the child has any general danger signs or stiff neck, treat as very severe possible as very severe febrile disease. If the child has an identifiable cause of fever, provide treatment. And if there is no apparent cause of fever, do CBC again and look. About counseling the mother for fever. First, we counsel about safety net. Child with fever, we should tell the mother, return the child immediately if any general danger signs seen, stiff neck, develop new complaints like skin rash, dysuria, or become sicker. In the home care, we advise the mother to reduce temperature during illnesses. For any sick child, reduce the heavy clothes on the child and use tape water baths for short period, increase fluid during illnesses, take antibiotic medication 6 hours, especially in the first 2 days. Advise the mother to increase fluid during illness. For any sick child, breastfeed more frequently and for longer at each feed. If child is taking breastfed, substitute, increase the amount of milk given. Examples like give soups, rice, water, yogurt, drinks, or clean water. For promotion advocacy, we advocate or advise the mother for next will child visits and immunization if proper. Thanks for the listening.